vaccination.
Thanks, Chris. And thank you for organizers for inviting me, but more importantly, thank you to the organizers for including GBS on the scientific agenda. And the reason I say that is what I hope to achieve over the next 20 minutes or so is really to convince you that group B strep, when I talk of GBS, it's not Guillain-Barré syndrome. It is group B strep. What I'm going to try to convince you is just how under-recognized it has been in terms of its public health importance, especially in low-middle income countries. And much of the reason for that is because of the success of having controlled the burden of disease in high-income countries through strategies which aren't necessarily possible in low-income countries. So this is data that's familiar to most of us, and that is the most recent update in terms of causes of under 5 mortality. And what strikes out from this data compared to earlier estimates in terms of under 5 mortality is that while there's been tremendous progress being made in terms of reducing mortality in a 1 to 59-month age group, especially mortality due to pneumonia and diarrheal disease, where we have lagged is a reduction in mortality in the neonatal period. And most importantly, what's happening in 2015 is roughly 45% of all children that die would actually die in the first month of life. But more important than that is that of those children that die in the first month of life, in fact, almost 2/3 actually die in the first week of life. And of those 2/3, closer to another 2/3 actually die in the first 72 hours of life. So I think that's important just to keep at the back of your mind as I go through the rest of the presentation. Of the neonatal deaths that do occur, 22%, about 1/5 of it is due to neonatal sepsis or infections. Another 1/3 of it is due to prematurity and complications of prematurity. And I think that's a category which I also ask you to keep at the back of your mind, because the causes of mortality in that particular group is pretty much ill-defined. And in fact, if you look at group B strep as an example, premature children are at least at about a 2 to 3-fold greater risk of developing invasive disease from GBS. And the case fatality ratio when they do develop GBS is about 2 to 3-fold greater than invasive GBS disease in a term infant. So Kathy has sort of already alluded to this. What is the value proposition of maternal immunization? There's a possibility of us being able to reduce mortality during the neonatal period because of infections. There's a possibility of us also possibly being able to impact in terms of direct causes of infection in the preterm babies. But more important than that is a possibility, as Kathy has alluded to, of us being able to actually prevent preterm birth from taking place in the first instance. And I think, again, that is something I'm going to come back at a later stage. What Brad emphasized yesterday is we shouldn't forget adults. And Kathy has also sort of made mention of this. And what I'm really referring to is that in addition to being able to protect the infants of the babies that are born to these mothers that are vaccinated, there's obviously the potential to actually protect the mothers themselves. And the same thing applies for group B strep. But what I believe has been really, really under-recognized in terms of its public health importance at a global level over the past decade is the whole scientific agenda of stillbirths. And certainly in the year 2015, there are more women that give birth to a stillbirth, roughly about 2.6 million, than the total number of children that actually die in the neonatal period, which is just over about 2 million. And I'll come back to that as well. So what I'm going to do over the course of the next 15 minutes or so is really first to try to define what is our understanding of the burden of vaccine-preventable GBS disease, both in neonates as well as young infants. What is the possibility of a maternal GBS vaccine being able to actually protect the mother, including actually preventing adverse fetal outcomes? And then lastly, just to try to share with you some data that we've accumulated recently in terms of whether a GBS vaccine could actually impact on colonization in the pregnant woman, and in doing so actually reduce the risk of exposure to the fetus as well as the newborn. So this is a slightly outdated meta-analysis published in 2012 in terms of the burden of invasive GBS disease globally. And what it basically tells us is that the incidence is highest in Africa, in addition to which the case fatality ratio is also highest in Africa, about 22%. What I didn't include in the study, in the slide, which wasn't really analyzed in this particular meta-analysis, is what we heard about earlier, and that is sequelae. So roughly about 25 to 30% of babies that survive an invasive GBS episode would actually have subsequent neurological sequelae in low-middle income countries, compared to about 10 to 15% of babies surviving in high-income countries. So the summary of this particular meta-analysis was the need for more high-quality studies to accurately estimate the burden of invasive GBS disease. Now, for those of you that might not be familiar with GBS, just a brief introduction. Basically, there are a number of maternal risk factors which are associated with the heightened susceptibility of the neonate developing invasive GBS disease, and those are listed here. But what is absolutely necessary for a child to develop invasive GBS disease in the first few days of life is maternal colonization. So without maternal rectovaginal colonization, a child simply is not going to develop invasive disease in the first few days of life at least. So how does the fetus itself become infected? There's one of two possibilities. It might be that as the fetus is passing down through the vaginal canal, that the child becomes colonized and infected. But what I believe is more common is basically an ascending infection. An ascending infection that's taking place in utero, and what's actually causing the child to actually become infected and actually develop disease, as I'll show you, before the child is actually born. Now, there's sort of a back-of-envelope calculation which was sort of worked out in the US before the era of intrapartum antibiotic prophylaxis, and that is trying to estimate what is the number of children that will develop invasive disease in relation to the prevalence of colonization in the mother. So if you were to take women that are colonized with GBS, about 50% of the babies will become colonized themselves. Of those 50%, roughly about 2% will actually develop early onset invasive disease. Now, these data basically are very much corroborated by a more recent study from South Africa where we do not have an intrapartum antibiotic prophylaxis strategy. In that we enroll a cohort of 5,000 women, 57% of those newborns became colonized and exactly 2% of them also developed invasive disease. So we seem to be having some sort of a back-of-the-envelope calculation which should allow us to be able to get some level of estimate in terms of the burden of at least early onset invasive disease in different settings. And this is where part of the contradiction arises. So when we look at the prevalence of colonization in pregnant women, it really varies very little between different settings. So basically, roughly about a 1.5-fold difference between what is observed in Africa compared to what is observed in Southeast Asia. But when you look at the reported incidence of early onset invasive disease, there's almost 20-fold difference between what is actually observed in Africa and what is observed in Southeast Asia. So obviously, something is not actually working out here. And remember, in Southeast Asia, they also do not screen for GBS colonization during pregnancy, and they also do not use intrapartum antibiotic prophylaxis. So if we were to apply the back-of-the-envelope calculation in terms of the expected burden of early onset invasive disease, those estimates would be roughly around about here, a much lesser difference between what is observed in Southeast Asia and what is observed in Africa. In Africa itself, the current meta-analysis probably underestimates the burden of invasive disease in that first few days of life. Now, as I mentioned, one of the reasons why there might be this disparity in terms of prevalence of colonization and the incidence of invasive disease, it might relate to the use of intrapartum antibiotic prophylaxis. And certainly in the US, that has been a strategy which has reduced the burden of early onset invasive disease by close on to 80 to 90% since it was introduced in the mid-1990s. But what has remained completely unchanged in the US over that period of time is that the incidence of late onset disease has remained completely unchanged. So much so that currently in the US, group GBS is a leading cause of bacterial meningitis in children under the age of 18 years. What the slide also shows you is the incidence of invasive disease, early onset as well as late onset in South Africa, which has remained completely unchanged over a period of almost 3 decades, including data now from 2015, 2016. Now, in addition to intrapartum antibiotic prophylaxis, what might be the other reasons why there's this sort of a disconnect between the prevalence of colonization in the pregnant women and the incidence of invasive disease? So it might be that there might be differences in terms of the serotypes that circulate in different regions, which might also have a bearing in terms of the virulence of the strains. There might be ethnic, genetic, host, or environmental differences to susceptibility to colonization as well as invasive disease. There might be differences in terms of natural immunity with regard to maternal antibody that's produced to GBS colonization. Now, all of these issues are currently being actually studied in a multi-centered study, which includes 3 South Asian countries and 4 African countries. And we hope to have data from that available in the next year or so. But then there might be an issue of case detection bias. And I think this is really where the big challenge lies. So why do I believe that case detection bias is an important issue? So this is data from South Africa. So currently, in terms of the incidence, South Africa reports the highest incidence of invasive GBS disease globally, especially from studies done in Soweto, where our incidence of invasive GBS disease is roughly about 3 per 1,000 live births, and that has been persistent for the past 15 to 20 years. But when we look at the incidence of invasive GBS disease in other settings in South Africa, what we find is that the incidence that's being reported is highest from two provinces, from Gauteng and the Western Cape. And those are the two provinces that got the highest GDP and got the highest access to curative healthcare services. If you go to Limpopo, Northwest, KwaZulu-Natal, in fact, they don't find any invasive GBS disease through the routine administrative databases. And the reason for that is the majority of children that are born in these provinces are actually being born in primary healthcare clinics. They are being born outside of facilities where there's diagnostic services. So even if the child has got respiratory distress, that child will receive a shot of antibiotic before the child is actually referred to the hospital for investigation. So there's a detection bias. And certainly in Southeast Asia, where a large proportion of children will be being born at home, let alone in primary healthcare facilities, again, many of these children will actually demise before they actually have an opportunity of actually presenting to a healthcare facility. So I think there's a major issue in terms of case detection bias. Now, what makes me believe this more firmly is that when you look at the spread of when the early onset disease is actually presenting, in the United States, before the use of intrapartum antibiotic prophylaxis, 90% of the early onset disease actually presented on day north of life. In South Africa, 95% of early onset disease actually presents on day north of life. And when I mention day north of life in South Africa, what I'm really referring to are children that are actually born with respiratory distress that have a blood culture taken almost immediately after the child is born. So these are not children that are actually being infected as they pass into the vaginal canal. These are children that are actually being born because of with an infection that has actually established itself while still in utero. Now, Brett yesterday made a lot of mention in terms of the differences between your vaccine attributable reduction and vaccine efficacy. Now, one of the major challenges that we face with characterizing the burden of GBS is we're really very much reliant on blood culture or CSF culture. In this particular analysis, what we looked at was early onset neonatal sepsis, and we had different criteria: a clinically suspected sepsis, a protocol-defined clinical sepsis, which was a much more stringent criteria using laboratory parameters, including CRP and other clinical criteria, and then culture-confirmed disease. So of all of the children that are actually admitted to hospital with suspected neonatal sepsis, about just under half of them would actually fulfill our criteria for clinically diagnosed sepsis, a fairly stringent criteria. Of those, only 10% will actually be culture confirmed. So 90% of children that actually have protocol-defined clinical sepsis, we do not know what the cause of it is. All that we can impute is what we find from culture-confirmed disease. If you look at invasive GBS disease, that's about 1/3 of all of the culture-confirmed disease that we actually identify, the most common cause of neonatal sepsis in the first week of life in South Africa. Now, what we've done to try to better characterize this is that we've tried to look at using molecular diagnostics on whole blood, using the Tachman array PCR, to see whether we can actually detect additional cases of GBS, of invasive GBS. And the positivity amongst the cases, and in this particular study we included healthy controls, the positivity amongst cases was about 4 to 10-fold greater than in controls. Overall, in children less than 3 days of age, 7% of them were actually positive on PCR, and 15% of those between 4 and 89 days of age were actually positive on PCR for GBS. Now, put together with our blood culture positivity, firstly, what it tells us is that PCR itself is not 100% sensitive for identifying invasive GBS disease, but inclusion of a PCR, whole blood, basically almost doubles, more than doubles, our estimate in terms of the burden of invasive GBS disease. And I think this is an important tool that we might be able to use to better characterize the burden of invasive GBS disease, especially in settings where children are only investigated after they've received an antibiotic. So how does GBS compare to the other pathogens that are being targeted for maternal immunization? And these are data from South Africa. So this is basically looking at incidence of hospitalization for influenza, for RSV, for pertussis, and for GBS. And what you find is what stands out by far is hospitalization for RSV, roughly about 3,200 per 100,000 in terms of incidence. GBS, on the other hand, has got an incidence of about 270 per 100,000, and that is just based on culture-confirmed disease. But what we also realize is that the case fatality ratio for GBS is multifold greater than the case fatality ratio for RSV as an example, 17% compared to 1.2%. So in South Africa, where we have a birth cohort of about 1 million basically what we know is that roughly about 550 children will actually die from invasive GBS disease compared to about 400 for RSV. So the number of children that die of invasive GBS disease, just based on culture positivity, is greater than those that would die between influenza and RSV combined in children under 6 months of age. And remember that the sensitivity of diagnostics for influenza and RSV is close on to 100%, compared to a sensitivity of diagnosing invasive GBS, which is probably close on to 10%. So clearly in a South African context, a vaccine against GBS would be of much greater public health value than vaccinating against RSV or influenza, at least when in terms of mortality, not necessarily in relation to morbidity. So what is the additional association between maternal infection and adverse fetal outcome? And what I'm going to focus on is really the story of stillbirths and preterm births. Now, firstly, what is the burden of invasive GBS disease in pregnant women? And there isn't any data from low-income countries to actually characterize this. The only data that I was able to find is slightly outdated, and that is from the US. And essentially, in the era of intrapartum antibiotic prophylaxis, the burden of invasive GBS disease in pregnant women was about 1/3 of what it was compared to early onset disease. The majority of these cases that occur in pregnant women is actually invasive disease related to infection of the amniotic fluid or the placenta itself. So consequently, 60% of this invasive disease is associated with spontaneous miscarriage or stillbirth in the United States. 5% of this invasive disease results in clinical infection in the infant. Another 4% were associated with induced abortion. And about 1/3 of the babies that were born to this woman were actually healthy babies. Now, as I mentioned, stillbirth is clearly an under-recognized public health problem. I mentioned that roughly 2.7 million women would have given birth to a stillbirth in the year 2015, compared to about 2.2 million neonatal deaths that actually occurred in 2015. The burden of disease, in terms of the incidence, it ranges anything from about 45 per 1,000 births in Pakistan. Now, we recently completed the meta-analysis in terms of exploring this association of GBS in relation to stillbirths. And these are data that date back to studies done from the 1970s. And we were able to identify less than 20 studies that were actually specifically address this question of the association of GBS to stillbirths. A summary of this data is basically across the studies, the proportion of studies which were associated the proportion of stillbirths that were attributed to GBS ranged between 0 to 12%, with an incidence of 0.04 to 0.9 per 1,000 births. On average, approximately 15% of all infection-related stillbirths were thought to be due to GBS. Now, this is some more recent data in terms of exploring what is this association between stillbirths and GBS. And this was a study that was done in Kenya, and I'm just going to quickly summarize this. In this particular study, they suggested that 2.2% of all stillbirths were actually due to GBS. And in fact, the incidence of GBS-associated stillbirths in this particular community was greater than the incidence of invasive GBS disease in the neonate itself. So what about another study from South Africa? And these are unpublished data, so I ask you to view it with a bit of caution. We did a large study that enrolled just over 300 women, where we were much more intensive in terms of investigating for stillbirths than was done in the Kenyan study. And this included taking cord blood at the time of delivery or a cardiac puncture to get blood, which was sent off for culture. We also undertook tracheal as well as gastric aspirates for culture. We examined the placenta for evidence of chorioamnionitis as well as for culture. In the South African context, using different criteria in terms of certainty of association with stillbirths, and definite would have been where GBS was identified either on cord blood or the heart blood sample. Probable was where there was chorioamnionitis with the presence of a gram-positive cocci on placenta, or GBS that was identified cultured on placenta or the skin, or where there was a pure GBS culture from gastric or tracheal aspirates, and then possible where there was just chorioamnionitis with the gram-positive cocci. What we find is that at least 5% of all stillbirths in South Africa are associated with GBS. If we were to include a probable, that adds another 8%. If we were to include a possible, that's another 8%. Overall, up to 20%, 1 out of 5 stillbirths in the South African context might actually be associated with GBS. And I asked you to go back to the previous slide I showed you in terms of early onset disease. Remember I told you that almost all of the early onset disease is taking place on a diagnosis based at the birth of the child. So what this tells us is that the early onset disease and the stillbirth is really a continuum of disease. Some children are fortunate enough to be born, others unfortunately don't actually make it to the first breath. And the reason why this is important from cost effectiveness analysis, and I was speaking to Ulla about this, is that stillbirths don't actually feature much in cost effectiveness analysis. In fact, they're not counted at all in a cost effectiveness analysis. Yet, the only difference between many of these stillbirths that are actually being born at a time of full gestational age is that they simply haven't taken one single breath compared to a child that's born at 24 weeks of prematurity, as an example, who's counted in terms of the cost effectiveness analysis or the cost analysis. So in a South African context, the incidence of GBS associated stillbirths, if we include definite probable as well as possible, is about 4 per 1,000, which again would be greater than the incidence of invasive GBS disease. Now, to further emphasize this point, I'm just going to share, I know this is not a basic science meeting, so I'm not going to put too much emphasis on this, but I think it's an important lesson. There's some important messaging. Now, the mice model is not a perfect model in terms of understanding the association of colonization and fetal or disease in the neonates. But in this particular study, what they did is they took mice, they basically got them colonized with the wild-type strain of GBS, which included the beta-hemolysin cytolysine expressing protein, which is a toxic protein, a pore-forming toxic protein. And then they had a knockout strain of GBS, which didn't actually have which didn't express this particular protein. What they found is that mice that were colonized with GBS roughly at about mid-pregnancy for the mice that were colonized with the wild-type strain, those mice had poorer weight gain during pregnancy. Both the wild-type strain as well as the knockout strain were able to actually infect the placenta of the mice. More so with the wild-type strain compared to the knockout strain, although that difference was not statistically significant. But where they did differ is that the preterm birth rate or the intrauterine fetal death amongst mice that that were colonized with a wild-type strain was actually much greater, 50%, compared to mice that were actually colonized with a knockout strain. Now, in addition to the direct effect of GBS on the placenta and on the fetus, there's some more recent study looking at an alternate mechanism by which GBS can actually cause poor fetal outcome. And the focus of this year is basically looking at membrane vesicles, which are secreted by GBS. They're also secreted by gram-negatives and other gram-positive cocci, but this is the first time where it's really been characterized in relation to GBS. What these membrane vesicles basically contain is a number of different proteins, including proteases and other pore-forming toxins. What was shown in a series of studies in this particular article, reported in this particular article, was these membrane vesicles were able to cause collagen degradation of the chorioidecidual membrane. These membrane vesicles were also able to basically passage from the lower reproductive tract into the uterus, in addition to which they cause an upregulation of pro-inflammatory cytokines and inflammation of the placenta, which mimic chorioamnionitis. The outcome of this year is that when given an intraamniotic challenge of the membrane vesicles, the birth outcomes amongst mice that basically receive the membrane vesicles was almost uniformly fatal. Now, the reason why this is important is it tells us is that we might actually get a poor birth outcome in the absence of actually culturing GBS in that particular individual, in this particular mice, obviously it's in mice. So in the absence of actual infection of GBS of the placenta is purely by virtue of the toxic effect of these proteins that can actually cause the stillbirths or the fetal loss. So the last 2 or 3 slides in terms of the potential of a GBS polysaccharide conjugate vaccine to actually reduce maternal rectovaginal colonization. This was a longitudinal cohort study that we did, where we basically enrolled women at 20 to 25 weeks. We sampled them every 4 weeks, and then we looked at the risk of acquisition of GBS, rectovaginal colonization with GBS during pregnancy in relation to capsular antibody at the time of enrollment. What this study basically showed firstly is that the prevalence of GBS colonization remained fairly stable over the second and third trimester of pregnancy, but most importantly, the 50% of pregnant women would be colonized at least once between 20 weeks and term gestational age, 50%. What the study basically showed is that women that remained uncolonized throughout pregnancy, they had higher antibody levels measured both by OPA as well as ELISA, and especially so for OPA for serotypes 1A as well as serotype 3, And then the study tried to get some sort of a correlate of protection against, for protection against acquisition of GBS in this particular population. What the antibody wasn't able to do was clear colonization. To clear colonization, what was required was the presence of cell-mediated immunity. And so what it really tells us is that for a vaccine to actually totally reduce, or have optimal activity against rectovaginal colonization, it would need to induce both cell-mediated immunity as well as humoral immunity. So is there any other additional data to support this? This is data from a monovalent investigational vaccine that was actually presented some time ago. It was a study done in non-pregnant women in the United States, 650 women. And women that received the conjugate vaccine, conjugated to tetanus toxoid, were actually less likely to become colonized with GBS throughout the observation period of 18 months compared to women that actually received a placebo. So it tells us that similar to other conjugate vaccines, a GBS conjugate vaccine could actually impact on colonization at the rectovaginal level, which would basically reduce exposure of the fetus as well as the neonate to GBS. This meeting is meant to be about the full public health benefit of vaccination, and I think it's important to emphasize that in addition to prevention of invasive disease in the first few months of life, there's also a burden of disease that takes place in the elderly, although admittedly the majority of these elderly are individuals with underlying conditions. About 80% of them would have some other underlying conditions. So with that, I just hope that I've managed to convince you that Group B strep is a real disease. I think our lack of understanding of its burden of disease really relates to issues in terms of diagnostics and case bias ascertainments. I believe that the vaccine targeted at pregnant women has got potential not to only protect the women, but also to actually improve their fetal outcomes, as well as to protect their infants. Thanks.